All right, as everyone gets settled, I'll go ahead and start session 2. My name is Catherine Kwik-Uribe. I'm from Mars Incorporated. I'm a member of the Food Forum and was part of the planning committee for this workshop, so I welcome you back this morning. In the second session today, we're going to continue on our journey on aging with the title of our second session, The Spectrum of Aging and Health Over the Lifespan. We have 3 wonderful speakers for this session. And in this session specifically, we're going to begin to talk a little bit more about nutrition, both under and over nutrition and its impact on the progress of aging. And we're going to continue to talk about the biomarkers of aging as well. So we have a full agenda as we've already identified. So what I'm going to do is I'm going to introduce each one of the speakers up front and then allow them to more fluidly go from one talk to the next. As with the previous session, we'll go ahead and have a discussion at the end. And so I'd ask you to reserve your questions to that time. And when you have a question, please step up to the microphone, identify yourself, and then ask your question. So as we already identified in the agenda book, as well as on the website, there is more information about each one of our speakers. So I'm just going to give a brief bio into each one. So our first speaker this morning is going to be Dr. Janet King. The title of her talk will be Early Life Origins of Metabolic Disease and Aging. Dr. King is a senior scientist at Children's Hospital Oakland Research Institute. She's a professor of nutrition at the University of California, Berkeley, and Davis. And Dr. King is recognized internationally for her research in maternal nutrition and human zinc requirements. She has a wonderful and long career, having published many papers and received numerous awards. Our second speaker today will be Dr. Luigi Ferrucci of the National Institute of Aging. His talk will be on biomarkers of aging. Dr. Ferrucci is a senior director of the National Institute of Aging, National Institutes of Health. Dr. Ferrucci is a geriatrician and an epidemiologist who conducts research on the causal pathways leading to progressive physical and cognitive decline in older persons. He has made significant contributions in the design of many epidemiological studies conducted in the U.S. and abroad. And our third speaker for our session this morning will be Dr. Gordon Jensen. The title of his talk is Overweight and Obesity in Older Persons, Impact Upon Health and Mortality Outcomes. Dr. Jensen is a Senior Associate Dean for Research and Professor of Medicine and Nutrition at the University of Vermont College of Medicine. Dr. Jensen's research interests have focused largely on geriatric nutrition concerns. And given the fact that the major limitation in the field is nutritional risk has a lack of validated methodologies, his team has emphasized the development of testing of nutrition screening and assessment tools in relation to specific functional and healthcare resources. And he applies these specifically in the context of obesity in his research. And with that, I'd like to invite Dr. King for the first talk.
Thank you very much, Catherine. When I first got the email from Anna inviting me to give this presentation, I was quite surprised. And I wrote back to her and I said, I'm sorry, but I think you have the wrong person. I do not study aging. I've been focusing on the other end of the life cycle for all my career. A few days later, she came back and she said, I consulted the program committee and they said they want you to give this talk. So here I am. And as I started thinking about it, it is true. There is really a strong connection between what happens in utero and what happens during our later years of life. So that's what I'm going to try to describe to you today. And I put together this little drawing to give you a visual picture of the cycle that we're going to talk about. I'm going to focus primarily on the pregnancy period and the nutritional status of the mother, how that influences fetal metabolism and growth, and also the secondary effects of how the child grows during the preschool years. Then, what is the link between that segment of the life cycle and the early adult years when we're beginning to see evidence of chronic oxidative stress and inflammation? And is that then a factor that's leading to the increase in metabolic diseases and aging associated with it? So, the very first evidence linking fetal nutrition and later health come from the observations made with regard to the Dutch famine that occurred during World War II. This is a natural study of severe food deprivation because Amsterdam was embargoed from December of 1944 to April of 1945 for a 6-month period. And the food supply that was available on average provided only around 400 to 800 calories a day, with limited amounts of protein, somewhere around 30 to 40. The city was liberated in early May, and the food supply immediately increased, and so that the average caloric intake went up about 5-fold to around 2,000 calories a day. But the result is that there was severe maternal starvation for 6 months, and it occurred at different stages of pregnancy. So one could examine what happens if the starvation was around the time of conception, mid-pregnancy, or late pregnancy. And Dr. Susser and Stein at New York spent many years combing through the data from the Dutch famine studies, looking at the effect of severe starvation at different stages of pregnancy. And what they found is that the outcomes of that severe starvation differed with the period of time in which the starvation was induced. So if it was around the periconception period, fertility went down. But if the mother did conceive, there was an increased risk of neural tube defects and effects on brain function, increased schizophrenia, and antisocial personalities that were detected in the later years of life. If she was in her first trimester when it was induced, there was an increase in the number of preterm births and more stillbirths, and an increase in the number of deaths of the infants during the first week of life. And then what was observed was an increase in obesity later in life. If the starvation was induced during the 3rd trimester, it interfered with maternal weight gain. This is the period of time when weight gain is the most rapid in women. And it reduced the birth weight of that child, but also in the next generation, there was a reduction in birth weight, and an increase in neonatal mortality between 0 and 3 months of age, and a decrease in obesity later in life. So quite different outcomes depending upon when the starvation was implemented. And it shows very strongly that fetal development is very dependent on nutrition during all stages of reproduction, and changes occur that are irreversible. Now, while Susser and Stein were looking at the Dutch famine data, Dr. David Barker over in England was also beginning to go back through all of the data that had been collected in England and in Wales during the 1920s, and evaluating the effect of nutrition of the infant or the fetus at that time on later health and disease. At that time, apparently, England and Wales were very thorough and careful to collect as much data as possible on the mothers during pregnancy, and they followed the growth and development of the children carefully as well. And what he reported in 1986 is that malnutrition in the womb changes the structure and function of the body for life, making the individual vulnerable to heart disease, diabetes, and stroke. That came out about 30 years ago. And he called this phenomena fetal programming. This then led to the development of the International Society for Developmental Origins of Health and Disease, what we refer to as DOAD. And in 2010, the leaders of DOAD expanded the scope of that society from just looking at undernutrition to also looking at the effects of overnutrition in the mother during pregnancy, as well as stress in the mother during pregnancy on fetal outcomes. So this is Dr. Barker's initial paper, published in Lancet in 1986. And as I said, he analyzed a large birth cohort of studies from different regions all over England and Wales. And he showed that there is a strong geographic relationship between ischemic heart disease mortality rates and infant mortality rates in that region 40 years earlier. So if there was a region of England where there was high infant mortality rates in the 1920s, they also then saw an increase in the ischemic heart rates in that same region 50 or 40 years later. And they found that it's the poor rural areas that had the higher rates of infant mortality than the urban areas. So it was evidence that if there was poor living conditions, maybe poor nutrition, that this was a critical factor. They found that the relationship between infant mortality and other diseases, respiratory diseases, cancer, those kinds of illnesses, was not as strong as it was with heart disease. So the conclusion that he made is poor nutrition in early life increases later susceptibility to the effects of an affluent diet in that individual. He then went on a few years later and extended his studies and looked using some data from Helsinki, and not only looked at the nutrition of the fetus, but also these data provided a lot of information on the nutrition of the child during the growing years. And they also then had a fair amount of data on adult disease in various regions. What he found was that the disease risk increased with a low birth weight plus a marked increase in childhood BMI between 3 to 11 years of age. So a child born small but growing rapidly during the preschool and early school age years. And what he found in comparison to infants with normal birth weight and childhood growth is that if they had this pattern of low birth weight and increased BMI, that the incidence of type 2 diabetes was increased by about 57% in that group, hypertension increased by 25%, and coronary heart disease increased 25% in men, but 63% in women. So that extra rapid growth does have an impact on risk for chronic disease later. So since these early studies by Dr. Barker, there have been hundreds of studies that have been performed involving at least 500,000 cases all over the world. And they show consistently that low birth weight is associated with type 2 diabetes, hypertension, dyslipidemia, central obesity, insulin resistance, and cardiovascular disease in adults, what we refer to as metabolic disorders. There's an inconsistent relationship with respiratory diseases, immunity, cancer, and psychiatric illnesses. And it appears that the brain growth is protected at the expense of the heart, lung, and kidney, which then contributes to the metabolic diseases later in life. So what we see from these data by Dr. Barker, Susser, and Stein, and others is that if there's undernutrition in utero, and still, if this child tends to be undernourished during early years of life, there is an increase in risk for metabolic disease because of the in utero exposure. But it is exacerbated if there was undernutrition in utero and overnutrition during the later growing years of life. But now we also have evidence that overnutrition in utero and overnutrition during the childhood years leads to an increased risk of metabolic diseases. There's a lot of data on this, and I'm just going to summarize it very quickly for you from this review paper that was just published not too long ago. But in obese mothers, it is found that among the fetal outcomes, there's an increase in stillbirth, neonatal deaths, congenital anomalies, large for gestational age, hypoglycemia shortly after birth, and many more of these infants end up in the ICU. I work at a children's hospital, and I know that for sure is the case. Childhood outcomes Of these children born to obese mothers, higher prevalence of obesity, associated with that would be adverse body composition, increased blood pressure, adverse lipid profile, which we also have in our clinics, increased inflammatory markers, and impaired glucose insulin homeostasis, early signs of metabolic disease in childhood, and then go on and develop a high blood pressure, lipid disorders, and a risk of type 2 diabetes and early mortality. What is interesting is that the mother's pre-pregnancy weight is more strongly associated with these adverse outcomes than her gestational weight gain, or the amount of weight that she gains during pregnancy. It tells us we should be trying to help obese women achieve a normal body weight before they conceive, but we have not been very successful in doing that. We also know now that obesity in the mother alters the placental structure and function that leads to an increased risk in disease later in life. There's just a review article that came out earlier this week on that very topic. We used to think that the placenta was very adaptable and could adjust to many of the environmental conditions that the mother is experiencing, but we now recognize that if she is obese, that there are changes in the structure and function of the placenta that influence the development of the fetus. And we also know that an excessive first trimester weight gain is a key factor for adverse later cardiometabolic profile in the offspring. So what this is telling us is the need to intervene prior to pregnancy and achieve a normal body weight. Let me say a few words about breastfeeding and later health. There's not a very strong literature on this for several reasons. It's very difficult to accurately determine breastfeeding exposures. Many women do not exclusively breastfeed, and the amount of formula that's given is not that well documented. But the data that we have are primarily from higher income countries, where the nutritional diet is better than in lower income countries. But some preliminary conclusions that we can draw now, this is some work done by Carolyn Fall over in England, is that in high income populations, breastfeeding is associated with a reduction in blood pressure, blood cholesterol, and a lower risk of obesity and diabetes as adults. And we also have a paper that just came out from UCSF a couple of weeks ago showing that early exclusive breastfeeding for 4 to 6 weeks is associated with longer telomeres at 4 to 5 years of age. It was done in a Latino group. So what mechanisms do we have that are linking nutrition to later health? And the one I'm going to talk about, I think there's probably a variety of mechanisms, but the one I'm going to talk about and focus on is DNA methylation, or the epigenetic effects that could silence a gene and thereby increase disease risk. And there's several ways that DNA methylation could occur in the fetus in utero. One, it may be related to the micronutrient intake of the mother. Folate, methionine, B12, choline, B6, riboflavin are all nutrients that influence methylation of DNA. But the other way in which it could be influenced is by the maternal microbiome. And there are data that are beginning to accumulate now showing that the mother's microbiome may produce metabolites that cross into her bloodstream and can induce epigenetic or methylation potential. That, of course, would also, her microbiome is going to be related to her diet. So these two factors are interrelated. So Andrew Prentice and his colleagues working in the Gambia have begun investigating the relationship between maternal nutrition and DNA methylation. And this is the first study that they did, where they asked the question, can we influence methylation of DNA in the offspring by giving women a supplement of micronutrients prior to conception and through the first trimester? So they randomized women to a multi-micronutrient supplement or a placebo from pre-pregnancy to the end of the first trimester. And what they found was that the preconception nutrition did influence the methylation of genes in the newborn. And the genes that were methylated differed between boys and girls. Maybe this is beginning to explain why women are more susceptible to heart disease later in life than men, or other factors. And that the methylation occurred independent of the season of the year. In the Gambia, there's a rainy season, which is called the hunger season. The dry season is when food is more plentiful. And they studied women throughout this entire cycle and saw that there were these changes irrespective of the season of the year. So they showed that maternal diet can influence the methylation of genes in the newborn. They then went on from that study and did 2 other studies where they looked at biomarkers of methylation in the mothers, also in conjunction with their diet, and again looked at the methylation of genes in the infant. As I said, there's marked seasonal variations in dietary intakes of components in the diet that are methyl donors. So the rainy season is the hunger season, and that's when the intake of these nutrients would be lower. But what they found was opposite to what they predicted. The blood biomarkers of methylation, folate, methionine, riboflavin, SAM to the SAH ratio, which is the ratio explaining the degree of methylation possible, was actually higher during the rainy season. And they then found that the offspring of mothers who conceived in the rainy season had higher levels of methylation of leukocytes and hair DNA, which is what they sampled in the newborn. So during the rainy season, when the mother's diet is more limited, there is an increase in components in her blood that can bring about methylation of genes in the infant, and there is an increase then in the methylation of their genes, silencing those genes. They also found, which is interesting, that those women that had slightly higher BMIs had less DNA methylation, indicating that maybe they were in better nutrition. So poor maternal nutrition at conception does enhance gene silencing in the newborn, and that may be a mechanism that is leading to metabolic disease later in life. So what we are beginning to think is that DNA methylation does occur as a result of maternal diet in utero. We also feel that silencing some of these genes could lead to an increase in inflammation and oxidative stress. There's a large literature on the relationship between DNA methylation and inflammation and oxidative stress, which may be precursors then to metabolic diseases of aging. So as you know, I do not work on aging, but I do work with an individual who has spent his whole life studying aging, both from when we were at Berkeley and now at Corey, Dr. Bruce Ames. And Bruce has come up with what he calls the triage theory. He predicts that micronutrient deficiencies cause DNA damage due to, well, he doesn't predict that, but micronutrient deficiencies cause DNA damage due to oxidative stress or inflammation. And he also says that they will cause mitochondrial decay and nuclear aging. He spends a lot of time looking at the mitochondria of the cells and the effect of nutrition in the diet. So he feels that if the micronutrient intake is limited, natural selection will favor short-term survival of key functions to stay alive at the expense of long-term health. So his hypothesis is, with micronutrient deficiencies of essential nutrients, they are triaged to support critical functions. This shifts reduce the availability of micronutrients to prevent oxidative stress and inflammation, which then could be the precursors for metabolic disease later in life. So I decided to test Bruce's hypothesis. I had to get zinc in here somehow. So we did a small study looking at increases in dietary zinc to see if they reduce DNA damage. So it's a study of 18 men fed a low zinc diet of 6 milligrams a day and then increased to 10 milligrams of zinc a day. And we measured oxidative stress by looking at DNA damage. We used the Comm assay, which measures DNA strand breaks, both single and double strand breaks, as a marker of oxidative stress and inflammation. And what we found was that during the depletion period, when the diet was low in zinc, the black bar indicates the degree of DNA damage increased. When we added the zinc back to the diet, it went down again. This is a very short, acute change. We certainly didn't expect to see this kind of a shift in DNA damage with such a small change. So, in summary, we've reviewed this cycle, focusing on this part of the curve, looking at pre-pregnancy over or undernutrition, how it affects fetal metabolism and growth, childhood growth. We're hypothesizing that DNA methylation might be a mechanism that predisposes the individual to oxidative stress and inflammation, which then could increase the risk of metabolic disease. The issue is, can we reduce this by improving nutrition, by better micronutrient intake, polyphenols, or also by caloric restriction? Thank you very much.